We still, yeah, we can still do it. Well, I think that the quick shot sessions are going a little bit long, so we'll wait just a couple more minutes and then get started. Okay, I've just gotten the directive from our management firm that we should start, so welcome to the second official day of the Southeastern Surgical Congress 2026. I thought yesterday was just a fantastic day and emblematic of what this organization is all about, fellowship and fun and uh, the information that was related through the various sessions was really quite exceptional. So the state of the art lecture for this year's meeting will be delivered by Murray Shames, professor and chair of the Department of Surgery at the University of South Florida. Murray, originally from South Africa, received his undergraduate degree from the University of Pennsylvania and his MD from Albert Einstein College, completed his surgical residency at the University of South Florida in Tampa. He followed the advice of a young vascular attending and did a one-year fellowship at the University of Sydney in Australia, and then returned to the United States to complete his vascular training at Washington University in St. Louis under one of the country's preeminent vascular surgeons at that time, Dr. Gregorio Sicard. Murray and I met in 1994 when I was a third-year resident and he joined USF as an intern. I spent 2 years doing basic research at the VA, and then when I returned, Murray and I's classes aligned, and I joined their class to graduate with him in 1999. That's when Murray went off to learn how to sew blood tubes together, and I was excited when he completed that training that he chose University of South Florida over Yale in 2002 for his first academic appointment under Larry Carey's strongly worded advice. Two former chief residents reunited in Tampa. Our friendship became stronger, first with yearly ski trips to his in-laws' chalet in Steamboat Springs, and then as fledgling triathletes. In my presidential address, I mentioned how hard it was to leave my elderly parents in Tampa when I moved to Greenville in 2007. Also on the right side of that Ben Franklin bomber list was leaving Murray and the camaraderie we had enjoyed running out and backs along Bayshore Boulevard along with Mitch Hoffman 3 days a week for 5 years, followed by a hearty breakfast and bitch session at the popular breakfast dive right off the boulevard after our weekend runs. We shared a common interest in cars and frequently lament about the one that got away from us, a 1995 air-cooled 911, which has resided in Montreal since 2013, Murray. Mine and Murray's stock has certainly appreciated since then, but not as much as that Porsche. When my dad became a dialysis dependent at the end of his life, Murray kept him alive by keeping his access patent until he couldn't, and then placed in him one of the first hero catheters at Tampa General Hospital. As a result, Murray became my hero, and I've waited quite a while to hear what he's really been up to since I left Tampa. Now, he's going to share that story with all of us in this year's state-of-the-art lecture, Management of Aortic Aneurysms, the Impact of Endovascular Techniques on Treatment and Resident Training.
Thanks, Manny. Thank you so much, Manny, for all of that. Do miss the running and the triathloning. Don't miss the part where you would leave me behind and finish the race, and I had 2 to 3 more hours to go. But anyway, today I'd like to congratulate Dr. Zervas on his presidency. That was a most moving presidential address, and thank you for the invitation to speak at this exciting meeting. It's a pleasure for me to speak about a topic that has defined much of the modern vascular surgery, the era of vascular surgery, and the evolution of the endovascular aneurysm repair, or EVAR. I can't claim that I had anything to do with the development of EVAR, but it has been an important intersection of innovation, technology, and my surgical career. These are my disclosures. So EVAR is often described as a success story of minimally invasive surgery. And in many ways, that is true. Less days in the hospital, quicker recovery, return to work. There's also a story of failure, and I mean that really in a very constructive way. Nearly every meaningful innovation in EVAR, the mechanisms of fixation, the device profile, the creation of fenestrations and branches, the management of the aneurysm sac, and ultimately total aortic endovascular repair has been a response to where EVAR did not perform as well as we had hoped. So today I'd like to walk through the evolution, where EVAR started, how it expanded, why it's failed in certain patients, and how those failures have pushed us towards the complex endovascular solutions that now we consider pretty routine. So aneurysms remain a major public health issue affecting millions of patients worldwide. And despite advances in screening and elective repair, ruptured aneurysms carry an unacceptably high mortality, often exceeding 25 to 30%. So for decades, open aneurysm repair was the only durable solution, and it set a benchmark for long-term success. But the cost was significant physiologic stress, prolonged recoveries, limited eligibility for many patients who just weren't candidates for surgery. So EVAR emerged not to necessarily replace open surgery, because it was intended for the high-risk patient who couldn't get an open operation. So the roots of aneurysm repair stretch back more than a century, from Rudolf Mattis's endoaneurysmorrhaphy, and I can't say that without reading it, in the late 1800s, to DeBost, first successful open repair in 1951. In there were coiling techniques where surgeons put metal wire inside an aneurysm sac to get it to thrombose, and actually cellophane wrapping of the aneurysm. So Albert Einstein actually had an aortic aneurysm. It had cellophane wrapping. Unfortunately, he succumbed to a ruptured aneurysm years later. And then it led to the refinement of prosthetic grafts in the 1950s by DeBakey and Cooley, which really established open aortic resection and replacement as a durable solution. So a huge paradigm shift occurred in the 60s with Charles Dotter, who introduced catheter-based vascular interventions. That shift from replacing blood vessels to treating them from inside the lumen, so endovascular, laid the intellectual groundwork for EVAR. And by the late 1980s and 1990s, stent technology, so really kudos to Dr. Julio Palmaz, who in 1988 got a patent for endovascular stents for cardiac interventions. But that was the framework for how we got to where we are now. So most of the earlier work occurred outside of the US without the regulatory framework of the FDA. So Nikolai Volodos was a Soviet surgeon, and he actually probably should be credited for the first EVAR, but he is not. That privilege goes to Dr. Juan Perotti. He was an Argentinian vascular surgeon who's widely known as the father of EVAR. In 1991, alongside his colleague Julio Palmaz, sutured a vascular graft, a polyester graft, to a Palmaz stent, put it in a delivery system, and inserted it into a patient as a tube graft, you can see in that diagram. So a sort of rudimentary repair. That technology was groundbreaking. So by using endovascular stents, he transformed the approach to aneurysm repair. So that first publication was in 1991. In 1992, I had the privilege of being a medical student at Albert Einstein, again, College of Medicine, where Dr. Perotti came down to work with my mentor, Frank Vieth. So Frank Vieth is the guy in the gray hair. So Frank is now 94, still runs his meeting in New York, but at the time was a visionary about sort of adopting endovascular technology. And they did the first EVAR in the United States at Montefiore with Mike Marin and Juan Perotti. And when I watched that, that was the transformation of my life, kind of sort of the Louis Pasteur, chance favors the prepared mind. I was like, that's what I want to do for the rest of my life. So after that, so this is sort of the fundamentals of, if you think about what an open aneurysm was, big exposure, clamp the aneurysm, resect it, and sew a graft proximally and distally. This was get access in the femoral arteries, deliver a device under X-ray guidance, some sort of fixation below the renal arteries and fixation in the iliac arteries, oftentimes with a bifurcated device. So sort of like a tinker toy, almost like putting pieces together, this modular reconstruction of the aorta from inside the artery, all under fluoroscopic guidance. So in 1999, the first devices were approved in the US. That's Tom Fogarty, the same guy as the Fogarty catheter, who really was instrumental in getting the Anurex device, which is the one with the kind of right next to him to the left. Multiple modular pieces fixated into the aorta with radial force, really no hooks, no screws, no springs, just radial force. You oversize the device and it stays in place. The one on the top left is the Ancure, which was probably the first device, really very rudimentary device, large delivery system, no support, big hooks that went into the aorta. And then there's development over time, proximal fixation, suprarenal fixation, barbs and hooks, and then refinement in the delivery system. So these devices had a number of limitations. Their fixation was highly dependent on anatomic factors as the neck length, the diameter, and the angulation. And these taught us really crucial lessons about anatomy and how anatomy dictated outcomes. So in 1999, sort of right at that time, I spent a year in Australia, which was a fantastic experience for me, but it was also, they had a lot of devices already approved. The vascular surgeons were already all doing this, so I had lots of opportunity to work with visionaries and really smart people who had done a lot of this work and go to a lot of wineries. So Palmaz, Fogarty, all also have wineries, it turns out. So kind of a nice environment to hang out in. These procedures were less invasive, the hospital days were shorter, and I got a lot of experience in EVAR. To come back to WashU, where we were just getting into clinical trials in Anurex and this Cook device. And I worked with Greg Siccardo, who had decades of experience of open aneurysm. So I got to do a lot of open aneurysm surgery, a lot of new technology, got to do some clinical trials and look at some of our outcomes and complications related to EVAR. I also got to work with Juan Perotti. So Juan Perotti joined the faculty just as I was finishing my fellowship. So that was an incredible experience. Here's a guy who invented the EVAR. I'm getting to hang out with him, learn from him. Phenomenal. I also spent a year in the lab working with Rob Thompson, trying to understand the pathophysiology, what makes aneurysms grow, how we can stop them. Turns out we have not figured that out yet, but we did a lot of work with doxycycline to try to inhibit MMPs. And then, as Manny said, went back to USF, where I was a new faculty member. I worked with Dennis Bandick. I got to really be the endo AAA guy. I did a lot of open aortic work. We worked with industry to develop clinical trials, got access to new technology. And one of my proudest moments was developing the Comprehensive Aorta Center, which was really to establish and to provide comprehensive care for patients with aortic disease and promote cutting-edge research and education. I got to work with Dr. Perotti again because his son Ezekiel was my first integrated resident. So in 2007, we started the integrated residency program. Ezekiel Perotti somehow appeared to be my first resident, and I got to train him, and he is now at UNC doing phenomenal work. So as the technology evolved, the devices got smaller. So what was like 22, 24, 26 French devices became 10, 12, 14, 16 French. We were able to go from open femoral access to percutaneous access. So sort of a rapid proliferation of percutaneous access. And so now this becomes a minimally invasive operation. 2 little percutaneous sutures in the groin, deliver the endograft, go home literally the next day. So during this time, we've seen this dramatic increase in EVAR. So the graph on your right shows the increase in overall aortic procedures, and the blue is EVAR. So really small, diminishing open surgery, pretty stable, but a massive increase in EVAR. And so sort of you got to think about why that is. What it turns out, the graph on the right is the comparison of the US and every other Western nation, and all the way to the left, you can see then we're the highest number of aneurysm repair for small aneurysms. So it turns out about 40% of our elective procedures are done in patients who do not meet size thresholds, societal size thresholds. So and that leads to significant complications. So if you look at one of the complications of EVAR, it's this endo leak where you get pressurization of the sac, either from poor fixation proximally, distally, or some component. and then or graft migration, which occurs because of inadequate sizing, unfavorable anatomy, improper technique, and just really poor judgment. So you're just trying to put the wrong device in the wrong patient. And so you get loss of seal, sac enlargement, potential rupture. So these predictors of EVAR failure are not mysterious, and they include liberalization of the anatomy, like I said, inadequate follow-up, and the devices are placed outside of the instructions for use, right? So this study by my colleague Andy Schanzer, there was significant at 42%, only 42% met criteria, and led to really poor outcomes, and 41% of those patients had aneurysm sac enlargement, so basically failed treatment. This is not a surprise when you look at the long-term data. This is multiple international randomized trials that showed while EVAR offers a really good early advantage for survival, that benefit erodes over time. And the comment really is that open repair in a healthy patient is probably a more durable operation, and that EVAR really requires a commitment to surveillance and secondary interventions. So we got to ask the question, if infrarenal EVAR is failing because of this fixation and anatomy, how do we address that without having everybody get open operations? So this is what it looks like to take EVARs out. This is multiple devices. So every one of these patients that had an EVAR, that had an attempted secondary EVAR, some endovascular intervention, and this is when you get to explant, the multiple, never mind the tens of thousands of dollars of devices that were put in, but the multiple operations to then get that open operation that you should have had the first time. This is some data from the Cleveland Clinic showing sort of the inflection point in the early 2000s where the red and the blue lines are the increased explants. Explants in the blue, and red was the endovascular treatment of failed EVAR. So sort of a rising, almost epidemic increase in secondary interventions. So why you say, well, is it so bad to take one out? Like it's just an operation, but multiple institutional series examining outcomes after EVAR conversion, 30-day mortalities range from 6 to 14%. Major adverse events in up to 46% of patients, and almost 20% of patients requiring hemodialysis. So it's a much harder operation than doing that EVAR open aneurysm the first time. This is our USF experience through 21. You can see about 20% of our open aneurysms were for explant for failed EVAR. So industry, and innovation did address that. There's multiple new strategies, polymer rings to keep the aneurysm in place with shorter necks, better proximal fixation devices. We can do endo anchors. So these are anchors inserted through a delivery system from the groin, which basically screw the endograft into the aortic wall, and really work better as a prophylactic tool. With proper sizing, you can get down to a 4-millimeter proximal neck instead of a standard 10 to 15 millimeter standard neck. So one way to do it. It doesn't really work so well when you're trying to salvage something that didn't fit in the first place. So this is some images of doing an endo anchor for a failed EVAR and trying to eliminate the type 1A endoleak. Other solutions were to fill the sac. So it's a device that actually has a polymer sac that you inflated after you put the endograft in and try and fill the space of the aneurysm. That device, unfortunately, did not make it through clinical trials. And the newer technology on the left is the shape memory. These are little polymer coils you put in around the aneurysm, the EVAR, at the time of implant to try and fill the sac with these coils to try and prevent type 2 endoleaks. And then we'll sort of address that proximal and distal components of branches for the iliac artery, conformability of the device to address angulation, and then proximal extension to include the visceral segment. So these two guys, this is Tim Tudor and Roy Greenberg. Roy on the right, unfortunately, passed away. He was at the Cleveland Clinic. Tim was actually a junior faculty member when I interviewed at Columbia for residency, and then he went off to UCSF. And the two of them own pretty much all the patents on everything to do with aortic graft fenestration and graft branches. Their contributions were focused on developing standard techniques and devices such as fenestrations, branch branch stent grafts, and really expanding the applicability of EVAR to cases that were previously deemed untreatable. So basically, this is the sort of progression of EVAR, infrarenal device all the way to the right, inclusion of the renal arteries and a sort of what we call a scallop for the SMA. Next generation includes a fenestration for the SMA and a scallop for the celiac artery, and then the next generation sort of as we've evolved over time. So data for ZFen is fantastic, very high rates of sac shrinkage. Turns out if you've got good proximal seal, your aneurysms shrink and aneurysms don't grow. So we do a lot of fen grafts. So this was approved in 2012. So take a look at this. So the evolution of EVAR, first device done in 1992. EVAR was approved in 1999. By 2003, so you see the rapid adoption, by 2003 surpasses open aortic surgery volume. The DREAM trial we mentioned, I showed earlier, sort of shows that there's good 30-day mortality. In 2011, we got FEVAR, fenestrated branched EVAR, and then nothing. So 24 years or so, 14 years or so of no new technology to address the proximal aorta. So surgeons are innovative. So we came up with our own solutions. These are parallel grafts, chimney grafts. So using standard EVAR devices and then other stent grafts, we're able to include the renal arteries, the SMA, address arch branches. Now, this was not without some, I guess, complications. So the durability was not great. You get these leaks around the gutters called gutter leaks. So long-term durability and results, while there's lots of case reports and small series that show excellent results, not really a durable solution. Yet we still tried. So this is a series of patients that I did by taking a standard Gore graft and then bringing multiple branches out of the what should be the contralateral iliac limb to put into the visceral segment. We did this a bunch of times. Again, the only solution we had, because we didn't have any commercial devices to actually treat the patients. So our physician-modified grafts became the solution. And this is sort of a selection of options. So building your own, taking a thoracic graft or an abdominal graft, kind of exposing it, and then adding fenestrations or branches or combination of fenestrations or branches. While the US really had no other devices, the rest of the world does have lots of access to commercial devices. And so there's a group of people, about 11 people in the US, called the Aortic Consortium, who actually had access to these devices, but really for the rest of us, kind of sort of on your own. I was fortunate in 2019 to be part of a clinical trial with a novel device. This is developed by a colleague of mine in South Dakota named Pat Kelly, and we partnered with Medtronic. We were able to develop this device, and we trialed it in 6 sites. We did 120 of them with what was considered really good, thinking about this, is type 2 and 3 thoracoabdominal aneurysms with only a 1.3% spinal cord ischemia rate and a relatively low reintervention rate and high primary patency. Unfortunately, Medtronic decided not to develop the device, and so the trial was ended. So then we really sort of transitioned back to this, what we call physician-modified endografts, which have really become the mainstay of our complex aortic practice. One of my colleagues is an outstanding surgeon. So with 3D imaging, CT scan, fusion, we're able to develop basically a model. You partially deploy the device. You make your fenestrations where the visceral vessels are, recapture the device, and put it in. So he has published a number of papers on our experience with excellent short-term and long-term results. We've also sort of transitioned to PMEG as our solution for failed EVAR. So you see the inflection point when Dr. Onatakas joined the team. Really very few open explants, and really transitioned to PMEG for most of our type 1, type 2, and type 3 endoleak failures. And the open repairs are really reserved for infected grafts or aortic fistulas. The rest of the world, I mean, the rest of the United States has also adopted PMEG. So while our site actually has an FDA physician-sponsored IDE to create PMEGs, the rest of the US really has adopted PMEG. And as more and more people have trained to do PMEGs, it's become pretty standard across the US. So rapid adoption of physician-modified grafts because of the absence of no commercial devices. So all that changed last year. This is the Gore excluded device. approved for thoracoabdominal and perirenal aneurysms. It's the first branch graft approved in the United States in over 13 years. The early trials, while they excluded a type 1 and 3 thoracoabdominal aneurysms, had 0 mortality, 7% major adverse events, 90% primary outcome success, and branch patency of 96%. So really transformational in the treatment of thoracoabdominal aneurysms, except that it is $75,000. None of this really would be possible without advances in imaging. So there's no longer possible to do a complex EVAR or any sort of aneurysm repair with a C-arm and a regular OR bed. So complex hybrid rooms have become the future. This is the new GE one we're installing. It's a robotic, very technically savvy, built-in CT fusion. The images on the bottom are from a company we work with called SIDAR that has cloud-based fusion. Upload a CT scan, it builds a roadmap, and then it's really cloud-based. You step on the pedal, the fusion image comes up, you know exactly where all your branches are when the patient's on the table. And then the issue is the radiation risk to the patient, but really the surgeon. Significant increased risk of cataracts, brain cancers, musculoskeletal injuries from wearing lead all day. So we're looking into options for non-radiation based imaging. So the top left is a fiber optic company called FORS. It's a partner with Philips, but also all image tracking devices, wires, catheters, have a little light you're attached to like a fiber optic cable, and you can see all of this in 3D with no radiation. So finally, I'd like to look at what has EVAR done to our training of our residents. So the rapid adoption of EVAR and the decrease in open AAA raises a critical question, along with the introduction of the integrated residency in 2007. So now, not only do we have vascular fellows, we have more than twice as many residents to train. So the APDVS did a study about a decade ago, and they really highlighted these concerns. And they predicted that by 2015, graduating vascular surgery residents and fellows would do only 10 open aneurysms in their training. And really by 2020, they'd only do 5. So, the world's ending. Who's going to fix all these aneurysms now? I think, advancement of endo is like many of those aneurysms will just be done endo. But as it turns out, the future was not so bleak. This is a current study. If you look at this infographic. No? Wrong. This one. The annual open abdominal surgeries really have not changed that much for residents and fellows. So while the numbers of aneurysm repairs are down about 85%, aortic iliac repairs are down 33% for occlusive disease, aneurysm total repair, open aneurysm repair, about 72% reduction. There's been a huge shift from the community to academic centers. So about 80% of all open repairs are now done at academic centers. And it turns out the residents are still getting about the same 18 to 20 open repairs in training. So we do need to think about what to do with that information. And how we address regionalization, simulation, other training paradigms for our residents. So really, the trajectory for us is quite clear. We're moving towards a total endovascular aortic repair supported by advanced imaging, data integration, modularity of devices. And the goal is not to really eliminate open surgery, but to really reserve it for patients who have no other choice. But we're doing TAVR to ascending with branches in the arch, descending thoracic aorta, visceral segment for all pathologies, aneurysms, dissections, redos, and really been quite impactful. So the future of EVAR is really the right patient with the right anatomy, with the right device, by the right team. So the evolution of EVAR has been anything but linear. It's advanced through enthusiasm, some disappointment, adaptation, by our surgeons and our innovators and our community, and innovation, really. Like this has really been, we've got to figure out how to do this on our own because industry did not really keep up. So the failures have taught us humility, innovation has taught us the possibility, and together they've brought us closer to a future where we have durable, minimally invasive aortic repairs for the majority of our patients. So thank you. So my family and then my work family, and Manny is going to be jealous. This is our new tower. So come back and join us. Thank you.
It was fantastic, Murray. You really as Larry Carey said, you know, he wanted to train leaders in general surgery, and I think that you've really changed the landscape of vascular surgery in Tampa Bay area and the country. So thank you for that. On behalf of the Southeastern Surgical Congress, I want to give you this little memento of today's state-of-the-art lecture.
Gonna put it next to all those triathlon medals.